Good morning, everyone, and welcome to Tyro Multidisciplinary Seminars. It is a new year, and I'm tremendously excited about the program this morning, as well as programming that we've got lined up for virtually all of 2023. I have the extreme pleasure this morning of introducing three of our guests. The first is Dr. Monika Krzyzanowska, who is a professor of medicine at the University of Toronto. She is a medical oncologist at Princess Margaret Cancer Center, and her clinical expertise is in endocrine and GI malignancies. She is currently the medical oncology endocrine site lead, and she is also the medical lead and chair for quality and clinical practice at Princess Margaret Cancer Center. She is Department Division Director for Medical Oncology at the University of Toronto. And Dr. Lucy Ma is a medical oncologist at the Princess Margaret Cancer Center. She is an assistant professor at the University of Toronto with a focus also on endocrine and GI tumors. Her clinical research focuses on the application of genomic profiling in both endocrine and GI tumors. And Lucy is the senior author on the paper that's being, or the first author on the paper being presented this morning, and Monika is the senior author. We are joined this morning by a person well known to not only the Tyro platform, but also to the entire international community involved in thyroid cancer care. Dr. Naifa Basaidi is a member of the Tyro board and a tenured professor at the MD Anderson Cancer Center. She is widely recognized for her clinical expertise and research contributions in the management of aggressive thyroid cancer. Her focus is on identification of molecular mechanisms for disease progression and the application of targeted therapy to improve patient outcomes. She has had a number of significant leadership positions, both nationally and internationally, and currently serves as member of NCCN Guidelines Committee for Thyroid Cancer, as well as a member of the board of ITOG. And I am thrilled to have all of you here this morning. I think it'll be a terrific discussion, and look forward to your presentations. So with that, I'm going to turn over the program to Dr. Ma and Dr. Krzyzanowski here.
Thank you so much, Dr. Erkin, for that lovely introduction, and it's great to be here this morning. So what we're going to talk about over the next 40-45 minutes is clinical application of next generation sequencing in advanced thyroid cancer. So before we begin, just wanted to include our disclosures. Most of mine are related to clinical trials participation and advisory boards with various manufacturers of drugs used in thyroid cancer, and Dr. Ma has no disclosures. So what we're going to talk about in the next 45 minutes is really to start us off by reviewing the molecular landscape of thyroid cancer, both in terms of the genomic alterations that have been identified, as well as some of the recent clinical trials with some of the targeted agents for some of these genomic changes. And then review some of the real world experience with next generation sequencing in the management, specifically of advanced thyroid cancer. As medical oncologists, this is what we see in clinic. I appreciate that there is applications earlier in the diagnostic pathway for thyroid cancer, especially with nodules, but we're going to focus really in the patient with metastatic and locally advanced disease, and finish off with some of the clinical implications and a path forward that we see. And now is the sort of perfect time for us to talk about this, as we have recently reviewed our experience at the Princess Margaret with next generation sequencing that we have been doing since 2013 as part of a larger institutional molecular profiling study. So it's not news to this audience, but thyroid cancer is really not one disease. In the clinic, we're often divide these patients, or we have managed these patients for many years now, as either medullary or sort of or the differentiated or anaplastic thyroid cancer patients. They do originate from different cells within the thyroid, specifically the peripheral T cell for medullary thyroid cancer and the follicular cell for the other thyroid malignancies. And we have known for a long time that genes played an important role in thyroid cancer. For example, for medullary thyroid cancer, in the hereditary space, the germline RET mutation is a well-appreciated molecular change that we have known about for a long time. And while there has been a lot of work in this space previously, the advancement in the molecular methods over the last 10 to 15 years with much larger panels and much more rapid analysis that's become available has really allowed us to understand the molecular landscape of these tumors, and in fact, the rich molecular landscape of many of these tumors. So what I'm going to do over the next few minutes is really review what some of these large sequencing analyses have shown us. So first, with the well-differentiated or sort of the lower risk papillary thyroid cancers, the Cancer Genome Atlas published their analysis of over 400 sort of low and intermediate risk papillary thyroid cancers. And what they found is, while the sort of molecular, the number of mutations per tumor was low relative to some of the other solid tumor malignancies, they were able to identify a molecular alteration in almost every patient in their analysis. And with the most common changes being in sort of within individual genes, especially within the BRAF and the RAS, so the MAP kinase pathways. With in their particular sample, almost 60% of patients of the samples had a BRAF mutation, as you can see in the top part of this onco panel. They also, as part of their analysis, looked at fusions, which have been reported in papillary thyroid cancer and other thyroid carcinomas. And in their particular analysis of 400 plus patients, they identified a number of fusions, the most common fusions that they saw with the RET gene, but they also saw some BRAF and obviously the NTRK fusions, which is another common area in this particular patient population. Next, moving on to the more poorly differentiated and the anaplastic thyroid cancer, another group looked at about 117 samples, 84 from poorly differentiated thyroid cancer and 33 for anaplastic, and also saw a large number of alterations. The difference that was seen between the more well-differentiated tumors and the more poorly differentiated anaplastic cohort was the larger number of mutations per sample. So the mutational burden was significantly higher, especially amongst the anaplastic cohort. And while the sort of culprit genes were quite similar, the distribution of the genes or the proportion of the cases having some of these genes was slightly different. BRAF was still, for example, the most common single alteration that was seen in this cohort, and obviously the common RAS mutations. But there were other differences, like for example the P53 mutation, which was extremely common. 73%, for example, of their anaplastic cohort had a P53 mutation. In the in another study looking at over 700, almost 800 patients with various differentiated thyroid cancers and almost 200 anaplastic thyroid cancers, which were profiled either using the MSK Impact platform or the Foundation One platform, they saw similar changes with a lot more genetic alterations per tumor within the anaplastic cohort, and a difference between the differentiated and anaplastic thyroid cohorts as well, with higher number of tumor suppressor gene alterations in the anaplastic cohort as opposed to the differentiated thyroid cancer cohort, and many of these being targetable with some of our recent agents, such as the BRAF inhibitors. Next slide, please. And so as our understanding of the molecular alterations in thyroid cancer has grown, I think the big question has been, well, that's great. It's important for us to understand this in order to understand the pathogenesis and eventually to help us on the therapeutic side. One of the big questions has been, how actionable are these mutations? And so the MSK group, the Memorial Sloan Kettering group, who's been running a large profiling study and has accumulated over 10,000 patients and published on this several years ago, when they had applied the OncoKB framework, which Dr. Ma is going to discuss shortly. Thyroid cancer was the second most common cancer in their cohort in terms of actionable mutation, with 60% of the patients in their cohort with thyroid cancer who were profiled having a potentially actionable mutation, meaning that there was an agent available that could be used for treatment. Next slide, please. So having gotten greater understanding of the molecular landscape of thyroid cancer, from the differentiated all the way through to the poorly differentiated and anaplastic. And obviously we already knew about medullary thyroid cancer and the high prevalence of either germline or somatic RET mutations. We now have the landscape of treatment has changed in the last several years with a number of mutation-specific therapies, including the NTRK inhibitors, lorlatinib and entrectinib, the BRAF inhibitors, and obviously the selective RET inhibitors, sulfatinib and pralsetinib. So I was going to go over some of the recent data with these agents. I should note that most of these have been evaluated in early, so phase 1 or phase 2 studies. So most of the data that we have on them is really response rates and toxicity, although some of the initial trials are now starting to publish some more long-term outcomes in terms of treatment duration. Next slide, please. So starting with lorlatinib and transfusion-positive thyroid cancer, this experience was published less than a year ago in the European Journal of Endocrinology. This included 29 patients from the various lorlatinib early phase studies, 21 of which had either papillary or follicular thyroid cancer and 7 with anaplastic thyroid cancer. The overall response rate in the thyroid cohort was about 71%, but as you can see easily from this waterfall plot, the majority of the responses were in the papillary and follicular histologies, although there were some responses within the anaplastic thyroid cohort. Next slide, please. In terms of our experience with BRAF inhibitors, and I'm glad we have Dr. Busaidi with us this morning, and she may comment, she's one of the authors of one of the studies on the BRAF inhibitors. We have, there was a phase 2 study with vemurafenib that was published several years ago, looking at about 50 patients who received vemurafenib either as a upfront treatment, so first line, or second line treatment, so after progression of on a VEGF inhibitor. And in that particular study, the response rate was slightly higher at about 38% in the first line treatment and about 27% in the second line treatment. In the study from Dr. Busaidi's group, they looked at, it was also a phase 2, a randomized phase 2 study where they randomized patients to either dabrafenib or dafrafinib and trametinib, and the response rate was about 30 to 35%. And you can see the waterfall plot from both of these studies. So we do see patients who respond, and some of these have durable responses. The other area where there's been some clinical data with BRAF inhibitors, obviously, is in anaplastic thyroid cancer. And for many of you on the line who treat anaplastic thyroid cancer, this was a welcome addition to our armamentarium of treatment, as anaplastic thyroid cancer there's been really a dearth of effective systemic therapies for this particular extremely aggressive disease. So as you saw earlier in the presentation, BRAF mutations are quite common in anaplastic thyroid cancer. And in the phase 2 ROAR study, the preliminary results were published in JCO in 2018 and showed some really positive results. An updated analysis was just published a few months ago, showing that the overall response rate in the full cohort was 57%. 6%, with some durable responses in a subset of patients. Next slide, please. Now, in terms of the selective RET inhibitors, so the experience with the selpercatinib was published in New England Journal a couple of years ago, and this focused on both the RET mutated medullary thyroid cancer patients as well as some of the other thyroid cancers with RET fusions. So what you can see on this slide is the two waterfall plots from the medullary thyroid cancer population. On the top there, the previously treated patients with either vandetanib, cabozantinib, or both. And in the lower plot, in treatment-naive patients, which was a smaller subset in this particular study. And as you can see, the response, there was high response rate observed in both cohorts, including a few complete responders. The RET fusion positive population in this particular study was smaller and included a variety of other thyroid cancers, including patients with anaplastic thyroid cancer, and responses were also observed in this patient population. Similarly, in the pralsetinib ARROW study, with similarly broken down by a previously treated MTC or treatment-naive population, high response rate 60 to 70%, and a high response rate in the RET fusion cohort of 89%. So really, this has been a very exciting time in thyroid cancer over the last few years with a number of new agents that have shown efficacy in terms of response rate, including some durable and potentially complete responses. But the big question, I think, now for us is really, where does molecular profiling fit in cancer in the clinic? As until recently, at least where I practice in Ontario, Canada, this has not been accessible except as part of a clinical study. So really, it's who, when, and how, and I'm not sure we'll have all the answers, but we'll have some, and then I look forward to hearing also from Dr. Busaide at the end about their experience in Texas. So I'll turn over to Dr. Ma to talk about our recent review and what our clinical guidelines from our various bodies are recommending in terms of profiling for this particular patient population. Lucy, over to you.
Thank you, Dr. Krzyzanowska. So as Dr. Krzyzanowska was mentioning in her previous slides, one of the reasons we wanted to do our study was to try to see, since access to this type of testing is becoming more available, however, is still limited mostly to patients who might have the opportunity to take part in research protocols that include this type of testing, or for those who have private insurance or the means to pay out of pocket. Although there are now drugs available based on the results of next generation sequencing, this is not yet standard of care for all patients. So really, we wanted to look at what the guidelines were recommending at the time that we conducted our study, as well as some of the outcomes at our institutions, that we could better counsel patients on the potential benefits of having this done, especially if it means taking part in a research study or perhaps paying a few $1,000s out of pocket for it. So at the time that we conducted our study, what we found was that the guidelines really had differing recommendations, ranging from the American Thyroid Association, granted the most recent version at the time that we were doing our study was from 2015. And at the time, they had not recommended routine mutation profiling in differentiated thyroid cancer, nor routine testing for somatic RET or RAS mutations in medullary tumors. More recently, though, the NCCN guidelines did recommend panel sequencing for several actionable alterations, including those with tumor agnostic, FDA-approved drugs approved. And also, the ESMO Precision Medicine Working Group released a statement which kind of left it to discussion between the physician and the patient, saying that this should be weighed against potential benefits and costs. And so really, this is what led us to do this study, was to look at some of the outcomes at our center. So we conducted a retrospective cohort study of advanced thyroid cancer patients who'd had molecular profiling done at our institution. And we used the OncoKB framework to categorize the molecular alterations by levels of actionability. And outcomes that we were particularly interested in was what proportion of patients had a potentially actionable alteration, how many patients had a level 1 or a level 2 alteration, and we'll review the OncoKB framework shortly. And finally, how many patients had their treatment directed by this kind of testing, meaning how many received drugs based on the result of their next generation sequencing. So as Dr. Krzyzanowska mentioned, the way that we were accessing this type of testing was through one of the research trials at our hospital called Octane, which enrolled patients with advanced solid tumors who were to receive systemic therapy and perform targeted panel sequencing on archival tissue. And so I think this slide highlights too that as our understanding of different significance of different gene alterations changes and their technology changes, so does the type of testing available to patients. So in our earlier years of the patients included in this study, it was a smaller panel of 48 genes tested, and the most recent one at the time that we were conducting the study was the OncoMine, which was a larger 161 gene panel, but also included analysis of gene fusions as well as copy number variants. So in total, we included 118 patients in our analysis. So the patients in our cohort had a median age of 53. Most had good performance status, ECOG 0 or 1. About half the patients had differentiated thyroid cancer, although we also included those with poorly differentiated anaplastic and medullary histologies. And as Dr. Krzyzanowska mentioned, as medical oncologists, we see patients in their more advanced stages of disease. So meaning that those with differentiated thyroid cancer were almost all radioactive iodine refractory at the time of enrollment. And the large majority of patients had distant metastatic disease. And here we looked at some of the patterns of use of this kind of testing. So we briefly went over the different panels that were used during the study. In terms of the tissue sample used for next generation sequencing, most patients had testing of their original thyroidectomy specimen, and patients were most often having this testing done before starting first-line systemic therapy, either with a tyrosine kinase inhibitor or cytotoxic chemotherapy. And so over the next few slides, we'll briefly review some of the alterations found, and I think for the sake of time, I'll summarize and say that what we found was consistent with what Dr. Krzyzanowska reviewed from the literature, meaning that those with well-differentiated disease mostly had their disease driven by mutations in the BRAF gene. So we had about 2/3 of the patients with a BRAF mutation, and of those, most were V600E mutations, and that this was mutually exclusive with mutations in NRAS and HRAS. We also did see, we had one patient with an NTRK fusion, and otherwise we found patients with alterations in the PI3 kinase pathway, genes involved in DNA damage repair, as well as tumor suppressor genes. With our poorly differentiated and anaplastic patients, we saw that BRAF and RAS alterations continued to be the main drivers of pathogenesis, although we did see that with more dedifferentiated disease, we began to see higher frequency of other gene pathway alterations, such as PI3 kinase pathway or tumor suppressor genes, including P53. And finally, in our patients with medullary thyroid cancer, we saw that almost all patients had a RET mutation. And again, this was mutually exclusive with mutations in RAS. And we saw that there was very low frequency of alterations in other genes and pathways in these patients. And so we then went and categorized these the molecular alterations that were found by the OncoKB therapeutic levels of evidence, ranging from level 1 to 2, which signify that the biomarker is predictive of a response to an FDA-approved drug, all the way to level 4, meaning that there's biologic evidence that the biomarker may be predictive of response to a drug. And what we found was that almost 90% of patients had at least one alteration that was potentially actionable. And of these, almost over half of the patients had a level 1 or a level 2 alteration, meaning that there was an FDA-approved drug available based on the testing that they had. Of these patients with level 1 and level 2 alterations, these were most commonly involving alterations in the RET and the BRAF genes. And so then we looked at the patients who went on to receive treatment as a result of their NGS. And at the time that we did our study, it was 15 out of the 118, so about 13% of the cohort. And so starting with our anaplastic patients, we can see that the most common gene alteration targeted was mutations in BRAF, specifically the V600E. And that I think what's remarkable here is that we had a few patients who were on the BRAF-directed therapy for a year, which for those of us who treat anaplastic thyroid cancer is really, an improvement compared to the usual disease trajectory that we see in these patients. I'll point out we did have one patient who was found to have an MSH6 deletion, and he went on to go on a phase 1 study at our institution and received an immune checkpoint inhibitor and actually had a complete response to treatment. So he received 24 cycles of treatment and then was on surveillance for a period of time, and then was eventually moved to a different province and was lost to follow-up at that time. Of our patients with medullary thyroid cancer, we had 3 patients who were treated with selective RET inhibitors at the time that we did our study. And these, what I'll point out here is that even in later lines of treatment, so this patient receiving second line was still on therapy a year after. And even in the third line, we had a patient who was able to be on a RET inhibitor for over 2 years. And finally, of the patients with papillary carcinomas, all patients received BRAF-directed therapy. And again, this was given in the first line or later lines. And what I would highlight here is that it really presents a nice option for treatment for patients who have a contraindication to lenvatinib or other multi-targeted tyrosine kinase inhibitors, which have VEGF activity. For example, if we're worried about the risk of fistulization due to disease in the neck, having a BRAF agent as another form of treatment at least allows patients some sort of treatment that without having to go to intravenous chemotherapy or other modalities like that. And again, we saw patients in the second and the third line who are able to be on this treatment for over a year or several years for some of the patients. As an update from this year, we've now had 22 patients go on matched therapy based on their NGS results. And this is still mostly in papillary thyroid cancer patients, as well as anaplastic, and the most common alteration targeted was BRAF V600E mutations. And we're now seeing that this is most often given in the first line of treatment. So if we compare our findings to some other studies in the literature, what we found, I think, was similar, meaning that other groups have also reported about 70% of alterations being in targetable pathways. And this other paper also mentioned that about 17% of the patients in their study were able to go on mutation-based targeted therapy. And for our cohort, we do expect this to further increase with time, as we looked at some of the reasons that patients didn't receive treatment based on their NGS results. And we had a large proportion of patients who either had not yet started systemic therapy or were still on their first line of therapy, and that mutation targeted therapy was being reserved for later lines of treatment, or for some of our patients who were enrolled in the study earlier, we may not have had the drugs yet for them, for example, the RET inhibitors at the time that they had their treatment. And I'll turn it back to Dr. Krzyzanowska.
Thanks so much. So as you just heard from Dr. Ma, from our experience and some of the other published studies, that sequencing is obviously feasible in clinical care, but until recently not really readily available. We've been fortunate enough at Princess Margaret that we had a large sort of institutional study where patients were able to be enrolled. I should mention that as part of that study, we did have, because of the stipulations of the study, which is to use archival tissue, there were a number of patients where we simply, the specimens that were available were just not of adequate, there was not enough tissue or not enough cells to really perform sequencing. As Lucy mentioned, we did see a high prevalence of actionable mutations, which is in keeping with previous studies, both clinical studies as well as some of the large profiling studies that I mentioned early in the presentation, but the actionability has been modest. And Lucy has already outlined some of Dr. Ma has outlined some of the reasons including the fact that some of these patients, so for example, several of our NTRK fusion patients are continue on surveillance at the moment, but also not just lack of access to testing, but also lack of access to the treatment. So the OncoKB framework focuses on FDA-approved agents. As a practitioner in Canada, that doesn't necessarily always translate into Health Canada approval. So we have faced some additional challenges with drug access. That being said, I do think that this is likely to change as the number of targeted agents has really grown in the last few years and continues to grow. And several of these new agents, like the selective RET inhibitors and the NTRK inhibitors, have received approvals in most of the countries around the world, and access and sort of reimbursement for those agents has either been secured or is under negotiation. So based on what we sort of seen and reflecting on the changes in the last decade around molecular profiling, we wanted to leave you with some of the recommendations, what we think is really should be the current state of next generation of molecular profiling in thyroid cancer, and which we apply in our clinical practice. We believe that all patients with advanced thyroid cancer being considered for systemic therapy should have molecular profiling of their tumor as part of their care. The big question really is when and how. So in terms of when, next slide, I think that for anaplastic thyroid cancer, this really needs to happen at diagnosis. Given the really rapid progression in most of these patients, we really can't wait. And in fact, at our own institution, what our pathologists have started doing is doing BRAF immunohistochemistry when the specimen comes in, while we wait for the next generation, the molecular sequencing, which takes longer. In the differentiated thyroid cancer population, this should happen at diagnosis of either radioiodine refractory, locally advanced disease, or metastatic disease. That being said, some of our patients, even in our cohort, despite having radioiodine refractory disease, are still on active surveillance. And as our methods improve, there can be downsides with using some of the older panels. The medullary thyroid population, obviously, if we know that the patient has a germline mutation based medullary thyroid cancer, we know that they have an alteration. But for patients who are germline negative, I think they should have RET testing, or they should have molecular testing, and we'll get to the type of testing in a minute, either a diagnosis of metastatic disease or or a diagnosis if they are not a surgical candidate. And there is a significant interest in the moment in the use of neoadjuvant therapy, especially in medullary thyroid cancer, for patients presenting with quite significant locally advanced disease, and whether a treatment upfront with some of these agents could potentially result in better outcomes. Next slide, please. The big question really is how. In the ideal world, every patient would have full next generation sequencing, but obviously these types of tests are quite expensive, and reimbursement remains an issue. So I think at minimum for the anaplastic patient population, we should focus on targetable genes, and this is the same for anaplastic and differentiated. In some health systems where access to even focused panels is a challenge, BRAF or NTRK immunohistochemistry could be done at minimum, and that's fairly cheap, and the panels are quite, the immunohistochemistry tests have good sensitivity and specificity. For the medullary thyroid cancer population, RET sequencing is at minimum. I think the full NGS, as we saw in our experience, really for most patients, the only times we saw any other types of alterations was in patients who were RET wild type. So I think if we were going to offer full next generation sequencing, it would really be in this RET wild type population. So key barriers, we already discussed some of them. I think reimbursement for testing remains an issue. As you saw, the guidelines have various recommendations, and I don't think other than the NCCN, none of them really strongly have recommended treatment. I think that may be changing, but the guidelines are only the first step. The payers then have to be willing to pay for testing, and we've certainly that's been an issue for us in our jurisdiction, although Cancer Care Ontario has recently approved a limited panel for testing for advanced thyroid cancer. The second issue is tissue availability. So as part of the Octane study, which is where we had offered next generation sequencing to our patients at Princess Margaret, we used archival tissue. We did have some issues with some patients in terms of the quality of the archival tissue, but also the other question is these cancers, as they progress, they acquire different genomic changes. So whether the if there may not be a driver mutation in the original specimen, whether we should actually be rebiopsying patients and doing next generation sequencing on the sort of new areas of disease, although that here is additional risks for patients. Biopsying a lung nodule is not without risk. And then the last thing, which you've already heard both Dr. Ma and myself mention, is this issue of drug access. So while drug access is improving, it remains a challenge, especially for some of the agents. Next slide, please. So I'm going to turn over back to Dr. Ma to talk about some of the other sort of outstanding questions.
Thank you, Dr. Krzyzanowska. So as Dr. Krzyzanowska already mentioned, one of the questions that we face in clinic is, what is the optimal specimen for sequencing? So as part of our study, as I mentioned, patients were having this type of testing done through a research protocol, which stipulated that we had to use archival tissue and we weren't allowed to rebiopsy. But I think the question still remains, how much spatial and temporal heterogeneity is there between genomic profiles of a patient's tumors as their disease advances? So it would be of interest to do paired sequencing of primaries, metastases, as well as blood to answer some of these questions. The next is, now that we have these drugs, where do we sequence them in our treatment algorithms? And there are studies ongoing, including one that's open at our institution, answering these questions. So we have these two studies, which are randomizing patients with RET mutated medullary thyroid cancer who have not yet started systemic therapy with a kinase inhibitor to either a selective RET inhibitor compared to the standard of care cabozantinib or vandetanib. So we await the eventual result of these studies. And then next, what is the role of liquid biopsy? And this is one of my areas of interest. Is, as we both alluded to, that tissue profiling might have some limitations, including access to tissue or what type of specimen you're using, whereas liquid biopsy using cell-free DNA or circulating tumor DNA might represent a more real-time representation of the patient's cancer's profile at the time that it's being done. And it could be used potentially both for mutation detection or monitoring of treatment. So as you can see from this study a few years ago, what the authors found was that tumor-specific variants in ctDNA could be detected and could either be used to monitor disease activity in patients who didn't have a conventional biomarker such as thyroglobulin available, or that sometimes these ctDNA variants could show disease activity and progression earlier than standard tumor markers in medullary thyroid cancer, such as calcitonin or CEA. And then finally, what can we learn about the mechanisms of resistance to treatment? And so this group published a paper of patients with lung and thyroid cancer who had treatment with RET inhibitors, and they performed longitudinal plasma cell-free DNA profiling. And as we can see here, they were able to identify some common mechanisms of acquired RET inhibitor resistance, including either on-target development of on-target alterations, which may interfere with drug binding, or activation of other pathways and other alterations in the MAP kinase pathway, for example. And so, I think this further poses questions such as, if we can detect these emerging mechanisms of resistance in a patient that's on treatment, are there steps that can be taken? Are there combination therapies that can be explored? Or, I think we also have to think, depending on what's driving a patient's progression or resistance to treatment, should their subsequent therapy be different depending on the mechanism of resistance? So to try to answer some of these questions, we do have a study open at our center, which we're enrolling patients with advanced thyroid cancer who are planned to start systemic therapy, and we're collecting pre-treatment blood and archival tissue profiling, as well as serial on-treatment blood and further profiling at the time of progression to try to see if we can answer some of these questions that we discussed. And I'll turn it back to Dr. Krzyzanowska.
So thanks very much, Dr. Ma. So just in a few concluding remarks, so I don't think this is not a new finding, but we know thyroid cancer is a molecularly rich malignancy, and as our methods have improved over the last decade and access to them, that's been further reinforced. We now have several alterations that are targetable with drugs, so they have therapeutic implications. The studies that have been done so far have shown modest sort of clinical benefit in terms of the access to drugs has been limited, and the drugs have sort of come of more recently, but I think much of that is related to the availability of the agents. However, now that we have commercially available testing options, I think molecular profiling should be part of routine care in advanced thyroid cancer. Optimal extent and timing of profiling is likely to evolve as we learn more. And at minimum, we should be looking at high prevalence targetable alteration for a particular histology, but ideally doing comprehensive panels. And so as part of that, I think it'd be important for us to advocate for reimbursement. I know the thyroid treating community in Canada has been really advocating so that we can have this available for our patients. I'll be curious to hear about the experience from the US, and I don't know if there's anyone beyond the US who may be attending this morning. So I'll stop there and just make sure we have an opportunity to take some questions and hear from Dr. Busady. So thank you very much.
Drs. Ma and Krzyzanowska, that was beautiful. I loved the presentation. I think you brought up all the key issues that goes through everybody's mind. And, I love the titles, by the way, of all your studies, right?
I'm not so sure about the beast title. That might be a little bit out there, but great for
They're attacking the beast. It's cool. I love it. We're always looking for cool names.
You need a good acronym, right?
For sure. In the endocrine world, we're always jealous of all the diabetes studies, but in the oncology world, it's all these, they have acronyms and everything else. So thyroid's got to keep up. I really, I resonate with a lot of your conclusions because it is important, right? It's time that we do molecular testing more. There are 13 FDA-approved therapies for thyroid cancer, right? 13. So we're way beyond, let's wait and test because we don't have anything. So I think your conclusions were spot on. And now we may even be using some of this testing to determine immunotherapy, who's going to respond to immunotherapy, either in combination with targeted therapy. So I think that all these things are very important. As you showed, I think Dr. Ma showed you had one patient that actually had a complete response, right, with anaplastic cancer, which again, these are things that were unheard of 2-3 years ago. So this is fantastic. I do love that you pointed out that 86% of all your cancers in your trial were had a level 1 or 2 what did you call it, OncoKB, right, framework, right, as a way to treat. And I do want to point out, I don't know if you want to show, well, you don't have to show the slide, but in DTC, you did use BRAF inhibitors first line in differentiated thyroid cancer, which I was very happy about. Not all our colleagues around the world agree with that. So the reason I want to point that out is, we do have these FDA-approved drugs. Dr. Ma, I think, had mentioned that there are reasons why anti-VEGF, lenvatinib, et cetera, may be contraindicated. And so BRAF inhibitors have much less or no VEGF activity, depending on the drug. and using those if somebody has severe hypertension or invasion of the trachea, et cetera, are important. But it's now, as of a few months ago, FDA approved in any BRAF inhibitors are FDA approved in any cancer, at least in the United States, in any cancer that has a BRAF mutation that has gone beyond first-line therapy, right? And so you could consider radioactive iodine and surgery first-line therapy. And so I think that was great that I saw that. So I do want to comment a couple of things and ask all three of you in terms of, if we're going to step back and say, when do we get it, right? Your recommendation, who do we get this molecular testing in, I think, was a great one, right? I think presumably all of us can agree that all advanced thyroid cancer patients who you're thinking about getting systemic therapy on, right? Because it takes time to get molecular testing depending on where you are. You mentioned access, you mentioned tissue. Not everybody has tissue. They might have had their thyroidectomy 20 years ago, right? And no lab has kept that. And so if there's somebody with distant metastases and or advanced cancer, even if it's in the neck, that you're thinking about systemic therapy or an approach that's not surgery, radioactive iodine, should get testing. And I would agree that I think we do a similar group. I think beyond that, there are many groups across the world that may use it in additional ways, right? Should we use it to determine surgery? That's an age-old argument. Should we use it to determine extent of surgery, or whether we give radioactive iodine? If the data is showing that many patients with BRAF mutations are resistant to radioactive iodine, then people are asking, well, why are we giving radioactive iodine? And I argue with the surgery and radioactive iodine part. I don't argue with the systemic therapy part, right? And so from a surgical standpoint, I think we need more proof that the extent of surgery does matter with the mutations. We don't subscribe to that. And from the radioactive iodine, we have patients who have BRAF mutations that take up radioactive iodine. They may be fewer than those that don't, but so we're not, well, most of us, some of our colleagues in Texas disagree, are not using it for that, but I don't think that's ready for guidelines. So I do agree with you in terms of, if we're going to say all of advanced thyroid cancer patients should be having this testing, our guidelines have a long way to go, right? I think you showed that beautiful slide where the guidelines are confusing, right? And one of the things I think Tyro always brings up is that many of these guidelines are not in real time, right? And they're 2015 is ancient, right? We've had a slew of drugs FDA approved since 2015 ATA guidelines. And then the ATC guidelines came out in 2021. So they're probably one of the more up-to-date ones. But, all the other guidelines say, well, maybe you should do it. And, and that doesn't help us with reimbursement, right? Whether you're in Canada or in, anywhere in the world, people look to guidelines for help. And so I think that we need to figure out a better way to do that. And I think your paper actually was, this topic is timely and beautiful that you summarize the key points. I think another point and that I am interested in is what type of testing, right? You mentioned that you did Oncomime version 3. And, that's great tests, right? And there's many companies that offer it. There are many academic institutions that have homegrown testing. And, people have their own biases about the sensitivity, especially with fusions. People argue, right? You hear this in the lung cancer world and the thyroid cancer world, that are we really picking up those RET fusions? Maybe we're missing them. And then people will, do their own test and pick it up and do another test and not pick it up. And so they conclude that one is better than the other. And I think I just want to mention that we don't have head-to-head studies looking at that with large enough numbers to say one is better than the other. So let's start with the baby step of what both of you mentioned, which is let's get access. Let's start testing, right? Let's get reimbursement. I mean, we need to start there and then figure out, okay, between these tests, some may be better than another. And because we do still have a large percentage of thyroid cancer patients or tumors that don't have anything targetable, right? And then what are you using in those? And what are we doing? Are we even looking in the right way? So, I do want to ask you all a couple of questions and see if Dr. Erkin, if there's any questions from the audience. But as an aside, understanding what these mutations mean, I think there are many studies and many people looking at it, which is very helpful. But I think even within the same mutation, look at what Dr. Krzyzanowski showed in terms of her larotrectinib in ATC versus DTC. The response rates in ATC were 29% if you had an NTRK fusion and 86% in DTC. So they respond better in DTC if you had an NTRK fusion. Now, if you go to BRAF mutations, in ATC, you had about an 60 to 80%, depending on what study you look at, response rate if you had a BRAF mutation with a BRAF inhibitor. And DTC, you had about a 27 to 35% response, right? And those are the same mutations supposedly. So there's a lot we don't understand, even though this is the tip of the iceberg, but I'm really glad that we're here. And I think when we talk about access and talk about testing with thyroid cancer, let's look at lung cancer, right? People all agree that it should be done in lung cancer. Why is thyroid cancer any different? I think we have enough data now to advance that. So I'll turn it over to Dr. Erkin before I monopolize. I have a few more questions and points I can make at the end, but I think that I do want to see if the audience had specific questions that we can address. Dr.
Yeah, so I don't think the audience questions, but maybe giving Dr. Krzyzanowska and Dr. Ma an opportunity to respond to your comments, Naifa, before we move forward. Do you have, Monika or Lucy, do you have any thoughts here that you want to share?
You know, so maybe I'll make a few and then turn over to Lucy as well. So first of all, Naifa, thank you very much for those comments. And, you know, I think we're all very passionate about our patients and getting them access to the best possible treatments. And, you know, I treat GI cancers as well, but I mean, it's in my thyroid cancer population that I see really, they're so rich in, the tumors are so rich in mutations. And now we have drugs, although FDA approval does not mean it's, as I said, Health Canada approval. So we struggle. And I think part of the issue has been that, you know, thyroid cancer, advanced thyroid cancer is still a relatively rare disease. So we don't have the same level of advocacy. And sometimes actually the companies don't even bother getting some of the drugs approved in other countries. Just to, so I've struggled with access. One thing I should say that, you know, we do use BRAF inhibitors up front if we think there's contraindication to lenvatinib, or which is the only drug that's reimbursed first line in DTC in Canada at the moment. Access has been an issue, but we have had some compassionate programs. But I do think we should be enrolling as many patients as possible in studies and somehow figuring out how to share this experience. Because as you rightly point out, even with the same molecular alteration, the response rates, like not everyone responds for the same duration of time. And, you know, we often share when things work, but we probably don't share as often when things don't work. And I think sometimes learning from our failures or when things haven't worked out the way that we expect helps us to advance our understanding and might help us with the sequencing piece as well. So I do think there's a second line BRAF study now for patients who've progressed on first line VEGF inhibitor. And I think that will be very sort of important to try to understand and help us with the sequencing business. But we need to figure out within the thyroid community, how do we share our experiences with some of the more rare alterations that have targetable drugs. So just to give you an example, we did recently have a medullary patient with an ALK fusion, and we were able to get them access to an ALK inhibitor, and they progressed right through it. So whereas there was data in lung cancer that this particular, an ALK inhibitor had great response rates. So I think we need to figure out a way of how we share this information as we get more access. But I don't know, Lucy, if you had any other thoughts based on the comments.
Yes, thank you. And thank you, Dr. Busaidi, for your comments. It's really always nice to learn from experts in the field, and to be able to speak with you about this is incredible. You know, some of what I grapple with are, you know, the questions that you brought up is what kind of testing should we do and when, and the extent, and, you know, what type of assay. I think for me, it's something I always think in clinic, because as we've seen, you know, the technology has evolved over time. And I'm always trying to think, you know, if we do this testing now and this person's not going to start treatment for, you know, X number of months or maybe even years, should we hold off? Should we wait? Will we have a better test, you know, at the time that they need treatment? But as, you know, you and Dr. Krzyzanowska pointed out, you know, we often have to take a step back and not even think, what's the best test we should do, or, which is the most up-to-date or sensitive test. But for a lot of patients, it's even, can we get access to testing? Because I think, we're very lucky at our hospital to have this research program open to get testing for patients. But, in a lot of other places, it might not be as readily available. And so I echo both of your sentiments on how, we really need to come together as a group and advocate for our patients, especially, in a rarer tumor site. And I look forward to future collaborations.
Great. Let me just ask you, how much of not a bias, but how much inaccuracy do you think entered into the study by using archival tissue as opposed to biopsying the recurrence or a metastasis? Do you have a sense on that, and how that would have influenced your outcomes?
Lucy, did you want to comment on that?
I mean, I think that's difficult to know without having the paired sequencing. I think that I think there have been a few other studies in solid tumors, for example, which have shown that in paired sequencing between primary and metastasis, there's often not a lot of change, and what perhaps introduces further development of new alterations is actually selection with treatment, where you select for subclones that then emerge as a result. But I think this is an area of interest, and we don't have the answer right now without doing the study.
Great. We do have a question from the audience regarding the average time to transformation to less differentiated or anaplastic carcinoma after the initiation of targeted therapy. And I hope that your current study will provide some information of potential markers that may indicate the possible complication of therapy. Would you like to comment on that?
It's a good question. Maybe I don't have an answer, to be honest with you. We do see patients with dedifferentiation on treatment. Sometimes I don't know if it's really dedifferentiation as a result of treatment, or is it that that's where they were in their pathway and we started the treatment, like I call it the art of the start, right? In differentiated thyroid, radioiodine refractory differentiated thyroid cancer, we're always having at every visit, it's like, is it now or is it later? And, most patients are not clearly no or clearly yes. They're usually mostly in that gray zone. And so I have had patients, where I've sort of felt go ahead and start on treatment, and they've sort of said, no, I'm not ready because I'm worried about toxicities. And most of those patients, by the time, sometimes it's taken me a year or two to convince them to go on treatment, and then they go on and they're the ones that have like very short response and they're differentiating. So, it's a really good question, but I'm not sure that I have an answer, or have I seen a study that has tried to answer this particular piece. So this, we often watch people for a while, and I don't know if we're because I don't want to, so I don't know if Naifa, if you've had any experience with this in.
No, I mean, it's a great question, Dr. Freeze, but I think dedifferentiation can happen on its own in differentiated thyroid cancer, like you mentioned. There is some question whether when we redifferentiate patient with these drugs and then treat them with iodine, are they at high risk for dedifferentiation? Again, the jury's out on that. And so I don't know, right? Is this the natural history of the disease? Is this our drugs and what's happening? So I agree with you. It needs to be studied.
So we are rapidly approaching the 9 o'clock hour. I would be remiss if I didn't just highlight the upcoming World Congress meeting that's going to take place in London in mid-June. And I'm sure everyone will find that to be incredibly informative in live and in-person meeting. I think maybe the best thing before I thank everyone, which I'd like to do for this outstanding presentation, Naifa, I'm going to turn to you and ask you what you think this conversation will look like 5 years from now.
It may not be a conversation. So 5 years from now, I think that all the advanced thyroid cancers hopefully will have more access and will be tested. I think that as these more and more tests come out and they become cheaper and cheaper, people will want to be doing them earlier and earlier. I just put a word of caution on that because I think we may make, conclusions when it's not necessarily true. I think that we'll be looking at patients that we can predict based on this testing who's going to respond to these therapies. For example, even if we just have a BRAF, it'd be beyond the BRAF discussion, right? 5 years from now, and who's going to respond and who's going to progress early using liquid biopsies, as Dr. Ma had mentioned. In terms of progression, I think 5 years from now, we'll even know what's the role of immunotherapy.
Terrific. You all, thank you very much. I'm sure we could go on for quite some time here. I enjoy it and invite everybody to join us next week for an International Tumor Board. And everybody's, thank you for joining us and stay well.
Thanks very much.
Bye-bye now.
Thank you.